Moving on to the special testing, and this first one we're going to talk about here is a range of motion measurement. That's typically the first one that you're going to jump right into once you finish with the palpation. So range of motion, we did talk about toe flexion and extension, and a little bit of toe abduction and adduction, but that motion right there, the abduction and adduction, it's not typically something that we would measure a lot or too often. So here in this slide, we're going to just focus on the toe flexion and extension. What we see here is a very specific goniometer that you can use for finger and toe flexion and extension. It's a very useful one for us to use. It's very easier for us to manipulate compared to the regular one. So we can use something like this and put that right on top of the foot to measure the degree of the toe flexion and extension. Each joint, each toe, you should have approximately 70 degrees of flexion and 30 degrees of extension. So what you're going to do is you're going to place that over the dorsal aspect of the foot and have, whether that's active or passive, you're going to maybe ask them to move, or you're going to passively grab the toe and then try to move into the flexion or extension. The next one is MMT, which stands for manual muscle test. We did only mention some intrinsic, very small, teeny tiny muscles here. So what we can do for the manual muscle test when you examine the foot and toes is you can try to examine the multiple muscles collectively as a group. It's impossible for you to really isolate a specific muscle here because each muscle is just so small. So what we can do is we can collectively try to assess the strength of the toe flexion. So if you are to say stabilize the foot here and apply teeny tiny resistance against the big toe and then ask them to flex the big toe, you are checking the flexor, halcus, longus, and brevis at the same time. If you are to focus on the second through the fifth, or maybe second through the fourth toe, you can check for flexor digitorum, longus, and brevis. If you have to focus on a pinky toe, you're checking the flexor digiti minimi, brevis, and then flexor digiti minimi together. Okay, you can also check for toe extension. Again, applying a very teeny tiny resistance up against the great toe extension to check for extensor, halcus, longus, and brevis. Or you can do the little teeny tiny resistance over the 4 toes to check for the extensor digitorum, longus, and brevis. You don't have a minimi for other extensors, but again, you're going to only check it collectively. You can also perform joint play, which you're going to grab one bone with one hand and another bone with another hand. You're going to create a little bit of a motion to play between those two bones. You can try to perform that in between metatarsals. This is what you're seeing here. Grabbing the first metatarsal, second metatarsal, and trying to glide on each other. That's intermetatarsal joint play. You can perform tarsal metatarsal, so securing a tarsal bone and maybe securing the metatarsal bone and the tarsal bone right there, trying to create this kind of a glide. You can also perform the mid-tarsal joint play. You can grab maybe like a cuneiforms, one like medial cuneiform and intermediate, and you can try to create some glide in between. What you would expect to see is a little bit of a motion with no pain. If they complain of pain as you are to play with it, or if you find increased motion or a super decreased motion compared to the other foot, that might indicate different things. If it's increased motion, then maybe it might indicate the laxity. Maybe there were some ligaments that got sprained or torn. If there's a decreased motion, it could indicate joint adhesion. Maybe the capsule got stuck together, maybe excessive scar tissue formation, or it could be more like osteoarthritis scenario where they start to build some excessive amount of the bone, so it doesn't really slide or glide anymore. Now moving on to more of an actual special test. The good one for you to know is the navicular drop test. So what we're going to do, or so what this test is designed to detect, is the amount of the foot pronation, how really flexible the foot is, and when they put weight on it, how much of a drop we're going to see in that foot. So what we're going to do first is we're going to palpate and find the navicular tuberosity. Okay, and you can place a dot on that. You can play a marker or put a sticker or something, whatever, so you can visualize the navicular. You're going to ask the patient to sit on the chair and keep the subtalar joint neutral at this point. Okay, so the 2 feet are placed on the ground, and then they're not really putting any weight on that foot just yet. From there, we're going to use the index card, something like this, Okay, and then mark how high the navicular is when they're not putting any weight on it. Okay, so you can use the card to place the mark. From here, okay, this is a non-weight bearing position, and you're going to ask them to now stand up. Okay, not on just this foot, but also with the other foot. So weights distributed equally among both feet. So maybe 50% of body weight per leg. So now they are now completely standing up. What you expect to see is a little bit of a drop of the navicular bone, and that's kind of a normal. You're going to see that drop. The question is that drop bigger than 10 millimeters? So we're going to use the card again to mark where it's at now, and we are going to use the ruler to measure the distance. How much did it drop? If it's bigger than 10 millimeter, we'll say that, okay, there was an excessive pronation happened in the foot, and you're going to say that was a positive test, okay, for excessive foot pronation. You typically see that nice disappearance, or at least a drop of the arch with it as well. Okay, another picture of checking the height of the navicular using the card. Okay, so a patient like this, I'm pretty sure it would probably give you a nice positive, unless this foot is probably maybe looking like this even with the non-weight bearing position. But you're gonna see a nice big drop of the arch with this patient. The other way maybe for you to check somebody's arch and then how they're gonna do compared to the non-weight bearing position to the weight bearing position, you can also perform the supple pes planus windlass test, which is a kind of a long name. But what you do is very simple. You're going to first of all, okay, check how their medial arch is doing when they're in a non-weight bearing position. So maybe they're just sitting on a chair, sitting on a table, not putting any weight on the foot, and how is their arch is going to look like. Ask them next, position number 2 is a full weight bearing position. So you're going to ask them to now stand up, okay, and put the entire body weight on those 2 feet. And how does it look now? Remember that my arch in class today, it completely disappeared, right? So probably in my arch, you saw some of that in a non-weight bearing position, but it disappeared in a full weight bearing position. The last position to check is the single leg heel raise position, which is here. So you're going to ask them to, okay, I want you to stand on one leg and try to raise the heel. This is actually a very good position for you to check for the windlass effect. This position is going to put some nice tension over the plantar fascia. So if it's still functioning okay, it should create some arch. Okay. So if you happen to see the arch in position position 1, but no arch in position 2, but then you can recreate the arch by putting them in this position number 3, then we can say, okay, this patient has supple pes planus, which is a very flexible type of pes planus. If no matter what you do, you just cannot see any arch whatsoever in that patient, that's a rigid pes planus. That's a positive test for the rigid pes planus. If they can still maintain the arch in the full weight bearing position, then we say that was a negative test, and then they don't have any pes planus. One more test you can use for arch is known as Feast line. This is also a very simple test too. What you're going to do is you're going to mark 3 specific structures. You can again maybe put the dot or something like that with a pen. So what we're going to do, we're going to find the apex of the medial malleolus. So it's right over here, and then you're going to find the very tip right here and put the dot. Next one, medial aspect of the first metatarsal head. Metatarsal head is a very distal portion of the metatarsal. Okay, and you're going to check the medial aspect, and this picture should be right over here. Okay, last one to check is the navicular tuberosity. That's a kind of good spot for us to visualize to really indicate how the arch is doing. Right here in this picture. Okay, so we're going to ask them to now again stand on 2 feet. On 2 feet, and then we're going to assess the relationship, okay, of these 3 dots that we just placed. You can kind of visually connect them. You don't have to really draw a line per se, but you can visually connect them to see how they are doing. If the navicular tuberosity happens to fall below the imaginary line that would connect between those 2 spots, it's below that line, we'll say, well, this patient would have pes planus. The arch is pretty low. If that's right on the line, we say, okay, that's a normal amount of arch. Okay, they still have a little bit of an arch, and that is normal. If that navicular tuberosity happened to be higher then the line that would connect the median malleus and first empty head, we say, oh, that's a pretty high arch. So we call that as pes cavus. Okay? So we'll say this is a positive test for pes planus, this is a positive test for pes cavus, and this is a negative test, arch is normal. The last one is a plantar fasciitis. This is, we kind of already talked about this structure, how it's going to start from the base of the heel and it's going to spread into 4 toes. This injury could occur as an acute injury or chronic. Interesting thing is they'll typically have pain. Their most tender spot is going to be right at the heel where the plantar fascia is going to start. And here's a very interesting pain pattern of this condition. They will typically have this worst pain in the morning. Why would that be? Well, because when you're sleeping, your foot is typically going to be located over the, like within the plantar flexed position. Okay? When you're plantar flexing your foot, and you can kind of try it yourself right now, you are taking the tension kind of away from the plantar fascia. So plantar fascia is in the kind of shortened, relaxed position throughout the night. Okay? So let's say you had a good night's sleep, and then you wake up, and then you try to take this nice morning first step in the day, and you're going to feel this worst pain ever. Why? Because now all of a sudden you are stretching the plantar fascia, which was relaxed and then in a shortened position throughout the night. So all of a sudden you're trying to stretch the structure. The first step in the morning is typically going to be the worst. Okay? So that's a nice question for you to ask. Also, the pain typically is going to increase when they try to walk and then try to push off. This is a windlass effect. Okay, the windlass effect is going to create more tension over the plantar fascia. When you have some pain going on, whether that's plantar fasciitis or plantar fascia pain, to keep it vague, it's going to hurt. Some other things that you might also find, not always, but maybe may be able to find, is maybe patient report some recent weight gain, and that starts to put a lot more additional stress over the plantar fascia, or maybe Achilles tendon or calf muscle is creating a lot of tension for some reason, and that tension would come down along with the Achilles tendon, maybe start to pull the heel up this way, and which would further put the tension over the plantar fascia. Some maybe chronic cases, you might see some exostosis formation right at the calcaneus, whether here or here. You actually see a little bit of a bone spur over here in this picture. Patient might have pes cavus or planus. Pes cavus, the arch is super duper high, which is going to create some tension over the plantar fascia. But when you have a pes planus and an arch is completely collapsing, that's also going to put some pressure over the plantar fascia. So either way, it could potentially put some extra stress over the plantar fascia. So you might be able to find some alignment issue as well.